Assalamu alaikum wa rahmatullahi wa barakatuh. Our lecture today is about the pituitary gland, discussing anatomy, physiology, investigations, and presenting problem in pituitary disease, including hypopituitarism and pituitary tumor. The pituitary measures around 13 millimeter transversely, 9 millimeter anterior-posteriorly, and 6 millimeter vertically, and weighs about 100 milligram. The pituitary gland is centrally located at the base of the brain in the sella turcica within the sphenoid bone. It is enclosed in the sella turcica and bridged over by a fold of dura mater called the diaphragma celli, with the sphenoid air sinuses below and the optic chiasm above. The cavernous sinuses are lateral to the pituitary fossa and contain the third and fourth and sixth cranial nerves and the internal carotid arteries. This anatomy is important to understand the complication of the presence of pituitary adenoma or tumors if there is suprasellar extension or there is lateral extension with pressure on the third, fourth, and sixth cranial nerve or internal arteries. The gland is composed of two lobes, anterior and posterior, and is connected to the hypothalamus by the infundibular stalk, which has portal vessels carrying blood from the median eminence of the hypothalamus to the anterior lobe and nerve fibers to the posterior lobe. The gland is composed of glandular tissue in the anterior pituitary, which is called adenohypophysis, and secreting about six hormones, and the neural tissue in the posterior pituitary, which is called hypothesis. This is simplified image about what had been talking about sphenoid sinuses, sella turcica with posterior and anterior pituitary glands enclosed within the sella turcica with this infundibular stalk connecting hypothalamus with the pituitary gland. About the physiology, anterior pituitary gland and posterior pituitary gland. Anterior pituitary gland secreting LH, FSH, thyroid stimulating hormone, prolactin, and growth hormone, and ACTH. Pituitary gland, anterior pituitary gland is under control by releasing hormones from the hypothalamus, like gonadotropin releasing hormone, which stimulate the pituitary to secrete LH and FSH, which in turn stimulate the target tissue, which is the reproductive system, to stimulate the production of sex hormone by gonads under the effect of the LH, and stimulate the production of sperm and eggs under the effect of follicular stimulating hormone. Thyrotropic releasing hormone from the hypothalamus will activate the pituitary to secrete thyroid stimulating hormone, which in turn affect the thyroid gland to secrete thyroid hormones, triiodothyronine and thyroxine T4. Prolactin releasing hormone is secreted from the hypothalamus, which activates the pituitary hormone to secrete prolactin, which in turn affects the mammary gland to promote milk production. Growth hormone releasing hormone secreted from the hypothalamus, which activate the pituitary to secrete growth hormone, which in turn affect the liver, bone, and muscle, induces targets to produce insulin-like growth factor, which stimulate body growth and higher metabolic rate. Corticotropin releasing hormone stimulating the pituitary to secrete ACTH, which in turn affect the adrenal gland, induces targets to produce glucocorticoid, which regulate metabolism and stress response. About the posterior pituitary, which called the neurohypophysis, is a storage of antidiuretic hormone, which is secreted from the hypothalamus and stored in the pituitary gland, which then affect the target tissues, kidneys, sweat glands, circulatory system, and have a role in water balance or water metabolism. Other posterior pituitary hormone, oxytocin, which affect the female reproductive system, trigger uterine contraction during child. Investigations of patient with pituitary disease. We have pituitary hormone excess and pituitary hormone deficiency. Regarding pituitary hormone excess, we have peripheral hormone and test for the diagnosis. Pituitary hormones include adrenocorticotropic hormone, which stimulate the adrenal to secrete cortisol. The peripheral hormone for the ACTH, or the mirror for the action of ACTH, is serum cortisol. The test for diagnosis to assess the hormonal, we cannot use the basal cortisone for diagnosis, so we use urine-free cortisol twice, or nocturnal salivary cortisol twice, or the use of overnight low-dose dexamethasone suppression test. Antidiuretic hormone, as we said, it is stored in the posterior pituitary from the hypothalamus uh, and affect the water metabolism. Test for diagnosis in the presence of the excess simultaneous serum sodium and serum osmolality, urine sodium and urine osmolality. Growth hormone, the image for him or the peripheral hormone indicating the presence of growth hormone is IGF-1, insulin-like growth factor 1. The test for diagnosis IGF-1 and growth hormone suppression test. TSH as a pituitary hormone, the peripheral hormone as a mirror for his function include thyroxine and triiodothyronine, T4 and T3. Test for diagnosis TSH and free or total thyroxine. For prolactin, it is secreted from the pituitary and the peripheral tissue, also the prolactin, and the test for the diagnosis is serum prolactin. About pituitary hormone deficiency, the pituitary hormone ACTH, the image for it in peripheral hormone include cortisol. Test for diagnosis simultaneous 8 a.m. ACTH and serum cortisol and confirmed by ACTH stimulation test. We will discuss later in other lectures. Antidiuretic hormone, the test for diagnosis simultaneous serum and sodium, urine and serum osmolality, just as the excess hormone. The confirmatory test, water deprivation test, LH and FSH, peripheral hormone, testosterone and estradiol, test for diagnosis simultaneous LH and FSH and 8 a.m. total testosterone in male and estradiol in female. There is no confirmatory test. Thyroid stimulating hormone, we measure TSH and free or total T4. About growth hormone, we measure IGF-1 as in the excess, but here there is confirmatory test including growth hormone, raising hormone, arginine, insulin tolerance, and glucagon stimulation and ghrelin agonist stimulation. In our country, we use clonidine stimulation test and glucagon stimulation test. Regarding radiological investigations, we establish by this modality of investigations the anatomy and be sure about the diagnosis whether presence of adenoma and its size and its extension. MRI reveal abnormalities of the pituitary gland in as many as 10% of healthy middle-aged people. It should therefore be performed only if there is a clear biochemical abnormality or a patient present with the clinical features of pituitary tumor. In other words, we do not suggest or use MRI of pituitary without underlying biochemical evidence of excess or deficiency, only in the presence of evidence of pituitary tumor. A pituitary tumor may be classified as either macroadenoma more than 10 millimeter or 1 centimeter in diameter, or microadenoma less than 10 millimeter dimension. The most common local complication of large pituitary tumor is compression of the optic pathway. The resulting visual field defect can be documented using Goldman perimetry chart. Establish the anatomy and the diagnosis, as we mentioned, imaging by pituitary by and hypothalamus by MRI or CT scan, and to assess the visual field defect, especially in the presence of macroadenoma or the presence of visual symptoms, or there is supracellular extension of the pituitary tumor. So you consider visual field testing by ophthalmology or CT. About the histology, conventional histology identifies the tumor as chromophobe, usually non-functioning, acidophile, typically prolactin or growth hormone secreting, basophile, typically ACTH secreting. Immunohistochemistry may confirm their secretory capacity, but is poorly predictive of growth potential tumor. Presenting a problem in pituitary, we have three entities: local complication caused by the local effect of the tumor, and hormonal excess if the adenoma it is secreting hormones, and hypopituitarism, which is deficiency of growth of pituitary hormones. Local complications including headache, visual field defect, disconnection, hyperprolactinemia, and diplopia because of cavernous sinus involvement, acute infarction, expansion called pituitary apoplexy. About hormonal axis, we have prolactinemia due to oversecretion of prolactin, which causes galactorrhea, amenorrhea, and hypogonadism. We have acromegaly, hypersecretion of growth hormone, which causes headache, sweating, change in show and ring size, or in another term, increase atral sizes. Cushing disease causing weight gain, bruising, myopathy, hypertension, etc., and depression. Hypopituitarism أو growth hormone deficiency سواء if it is one or two hormones or panhypopituitarism all the hormones. The growth hormone can cause lethargy, gonadotropin cause lethargy, loss of libido, hair loss, amenorrhea, ACTH cause lethargy, hypotension, pallor, hair loss, TSH cause lethargy, vasopressin usually post-surgical, thirst and polyuria. Classification of diseases of the pituitary and hypothalamus. We have non-functioning, as mentioned above, non-functioning tumors, hormonal excess, hormonal deficiency, hormonal resistance. Classification of disease of the pituitary. Non-functioning tumor ممكن primary pituitary adenoma, craniopharyngioma, and metastatic tumor. Hormonal axis, we have anterior pituitary and posterior pituitary. Anterior pituitary prolactinoma, acromegaly, Cushing disease, rarely TSH, LH, and FSH secreting adenoma. As a secondary, there is disconnection, hyperprolactinemia, hormonal deficiency, uh, hormonal axis from the posterior pituitary gland, hypothalamus, and posterior pituitary. There is a syndrome of inappropriate antidiuretic hormone secretion, which is called SIADA. Hormone deficiency include hypopituitarism from the anterior pituitary, cranial diabetes insipidus, which is deficiency of antidiuretic hormone. As a secondary causes of hormonal deficiency, there is gonadotropin releasing hormone deficiency, which is called Kahneman syndrome, which will patient present with insomnia and hypogonadism. Hormone resistance, growth hormone resistance, known as Laron dwarfism, and nephrogenic diabetes insipidus, in which the antidiuretic hormone to not act on the kidneys, which is causes polyuria, and preeclampsia, which is called diabetes insipidus. Hypopituitarism refers to either partial or complete deficiency of anterior and posterior hormones and may be due to a pituitary disease or to hypothalamic pathology which interfere with the hypothalamic control of the pituitary. The clinical presentation is variable and depends on the underlying lesion and the pattern of presenting hormone deficiency. The most common cause is pituitary macroadenoma, causing pressure on the normal surrounding pituitary tissue and end by hypopituitarism. Cause structural like primary pituitary tumor, adenoma, carcinoma, craniopharyngioma, meningioma, secondary tumor, chordoma, germinoma, arachnoid cyst, radical cyst, and hemorrhage, which is called apoplexy. Hemorrhage within the pituitary gland called apoplexy, which may cause acute presentation, inflammatory and infiltrative disease like sarcoidosis, infection, especially pituitary tuberculosis, syphilis, encephalitis, lymphocytic hypophysitis, hemochromatosis, with deposition of iron, Langerhans cell histiocytosis, congenital deficiencies including gonadotropin releasing hormone, which is called Kallman syndrome, present with hypogonadism, growth hormone releasing hormone deficiency, present with short stature, thyrotropin releasing hormone deficiency, and corticotropin releasing hormone deficiency. Functional causes include chronic systemic illness like severe renal impairment, chronic liver diseases, also anorexia nervosa, and excessive exercise, like in the presence of hypothalamic amenorrhea in patient exposed to heavy exercise or severe exercise to maintain low weight. This is end by functional or hypothalamic amenorrhea because of low LH and FSH. Other causes of hypopituitarism include head injury, para or cellular surgery, para or cellular radiotherapy, postpartum necrosis, which is called Sheehan syndrome, and analgesia. The clinical features depend on the type and the degree of the hormonal deficiency and the rate of its development, whether acute or chronic, insidious, in addition to whether there is intercurrent illness. This is mean one of example, the patient will have central hypocortisolism. he is well or nearly well until there is the current illness, stressful condition, severe infection, which is need more cortisol, and so patient may develop adrenal crisis. In the majority of cases, the development of hypopituitarism follow a characteristic order: secretion of growth hormone, gonadotrophin being affected first, followed by TSH and ACTH secretion, and at a later stage. Protein deficiency is rare. There is a wisdom from there is a wisdom from the God for this loss of secretions. TSH and ACTH it interfere with the life, so it is the last to be lost. Growth hormone not interfere with the life. Gonadotrophin not interfere with the life, so it is lost first. Thanks for the God. Antidiuretic hormone deficiency is virtually unheard of the pituitary adenoma, but may be seen rarely in infiltrative disorder and growth hormone deficiency in adult produce lethargy, and we mentioned about that growth hormone deficiency, ACTH deficiency, TSH deficiency, gonadotrophin deficiency, all present with lethargy. So in growth hormone, there is lethargy, muscle weakness, increased fat mass, but these features are not obvious in isolation. Gonadotrophin, LH, and FSH cause loss of libido in the male and oligomenorrhea and amenorrhea in the female. Later in the male, there may be gynecomastia and decreased frequency of shaving. Both sexes, axillary and pubic hair eventually become sparse or even absent, and the skin becomes characteristically finer and wrinkled يعني مجعد وخفيف. Chronic anemia may occur. ACTH deficiency resulting in symptoms of cortisol insufficiency, including postural hypotension and delusional hyponatremia, but with a striking degree of pallor is usually uh, is present. And one of the differential diagnoses of generalized pallor of the patient is hypopituitarism because of low ACTH. Abnormal plasma potassium in contrast to the primary adrenal insufficiency, which there is hyperkalemia. TSH deficiency causes secondary hypothyroidism. This contributes further to apathy and cold intolerance. In contrast to primary hypothyroidism, frank myxedema is rare, presumably because the thyroid retains some autonomous function. The onset of all of the above symptoms is insidious. However, patients sometimes present acutely unwell with glucocorticoid deficiency. This may be precipitated by a mild infection or injury, or may occur secondary to pituitary anorexia. This mentioned above. Panhypopituitarism is a condition in which adequate production of all anterior pituitary hormones is lacking, usually because of large tumor, apoplexy, or complication of pituitary surgery. Patients require daily replacement of thyroxine and cortisol first to be replaced. Replacement of sex hormone and growth hormone is individualized. This means that the patient need to be fertility or only for libido and sex. We debate this make the decision to choose which hormones will be replaced. Growth hormone is used only in selected cases and not replaced to all patients. Investigations of hypopituitarism. The aim of investigations of hypopituitarism are to biochemically assess the extent of pituitary hormone deficiency and also to know the cause about to know the cause causing hypopituitarism, basal hormone level, basal concentration of the anterior pituitary hormone, as well as the target organ hormone should be measured, as the pituitary hormone may remain within the normal range despite low level of target hormone. Measurement of the pituitary hormone alone does not demonstrate that the level is inappropriately low, and the diagnosis may be missed. LH and FSH and testosterone or estradiol, TSH and free T4, early morning cortisol and ACTH, prolactin and IGF-1. In acutely unwell patient, the priority is to diagnose and treat cortisol deficiency. Other tests can be then undertaken later. There is specific dynamic test for diagnosing hormone deficiency. All patients with biochemical evidence of pituitary hormone deficiency should have MRI or CT scan to identify pituitary or hypothalamic tumors. If a tumor is not identified, then further investigations are indicated to exclude infectious or infiltrative causes. How and when to use ACTH stimulation test, which is one of the confirmatory tests uses an ACTH deficiency. Diagnosis of primary or secondary adrenal insufficiency, assessment of hypothalamic pituitary adrenal axis in patients taking suppressive glucocorticoid therapy relies on ACTH-dependent adrenal atrophy in secondary adrenal insufficiency, so may not detect acute ACTH deficiency, example in pituitary apoplexy. Dose of sinactine 250 microgram ACTH or colsinactin by deep IM injection or IV at any time of the day. Blood samples taken at 0 and 30 minutes for plasma cortisol, 0 minutes also for ACTH if Addison disease is being considered. Patients don't know to have pituitary disease or to be taking exogenous cortisol. Results: normal subject plasma cortisol more than 500 nanomole per liter or more than 50 microgram per deciliter either at baseline or at 30 minutes. An incremental change in cortisol is not a criterion for diagnosis. This means how how much the cortisol increase after injection. This is not included within the criteria for diagnosis. The criteria for diagnosis, if it is above 18 microgram per deciliter, this is called normal response to the injected phenactine 250 microgram per deciliter. If less than this is considered poor response to tests of growth hormone secretion, growth hormone level are commonly undetectable, so a choice from the range of simulation tests is required. This includes insulin-induced hypoglycemia, arginine, glucagon, and clonidine in children. How and when to do an insulin tolerance test. Indications: assessment of the hypothalamic pituitary adrenal axis, assessment of growth hormone deficiency indicated when there is doubt about after the other test, usually performed in special center, especially in children. IV glucose and hydrocortisone must be available for resuscitation. Contraindication for using of this test: presence of ischemic heart disease, epilepsy, and severe hypopituitarism. Doses include 0.15 units per kg body weight of soluble insulin or regular insulin given IV, aim to produce adequate hypoglycemia, tachycardia, and sweating with blood glucose less than 40 mg per deciliter. Blood samples taken at 0, 30, and 45, 60, 90, and 120 minutes for blood glucose, plasma cortisol, and growth hormone. Results: normal subject growth hormone more than 6.7 microgram per liter, normal subject cortisol more than 550 nanomole per liter. For measurement of hypopituitarism, hormonal replacement, and specific treatment of the underlying pathology like pituitary macroadenoma may be required. Glucocorticoid replacement therapy consists of oral hydrocortisone 50 to 20 mg daily in divided doses, typically 10 mg at walking and 50 mg at around 3 a.m. 3 p.m. These are physiological replacement doses that should not cause cushingoid side effect. The dose may need to be adjusted for individual patient. Excess weight gain indicate over replacement, while persistent lethargy may be due to inadequate doses or lack of absorption. Mineralocorticoid replacement is not required as in the case of primary adrenal or disease. Thyroid hormone replacement, levothyroxine 15 to 150 microgram once daily should be given. It has half-life of 7 days, so it should always be taken as a single daily dose. Unlike in primary hypothyroidism, measuring TSH is not helpful in adjusting the replacement dose because patients with hypothyroidism often secrete glycoproteins that are measured in the TSH assay but are not bioactive. The aim is to maintain serum T4 in the upper part of the reference range. It is dangerous to give thyroid replacement in adrenal insufficiency without first giving glucocorticoid since it may precipitate adrenal crisis. The idea about this, the presence of giving thyroxine replacement will increase the metabolic rate, which needed more cortisol in the body. So, in the presence of glucocorticoid deficiency and increased demand for cortisol, patient will develop adrenal crisis without glucocorticoid replacement. Sex hormone replacement. This indicated if there is gonadotropin deficiency in women under the age of 50 and is meant to restore normal sexual function and to prevent osteoporosis. Estrogen testosterone administration is the usual method of replacement by gonadotropin, but gonadotropin therapy is required if fertility is desired. This is mean that sex hormone replacement is individualized according to the wishes of the patient. If the patient wish to be fertile, so we replace LH and FSH therapy to restore the fertility. If the patient do not wish to be fertile, we replace either estrogen for women or testosterone for growth hormone replacement. As we said previously, it is individualized and not used to the all patient. Growth hormone is administered by daily subcutaneous self-injection uses in children and adolescents with growth hormone deficiency and discontinued once the epiphysis has fused. In hypopituitarism, adults who remain lethargic and unwell compared with healthy population in spite of receiving full replacement with hydrocortisone, levothyroxine, and 6 steroid, as some of these patients feel better and have objective improvement in their fat muscle mass ratio and other metabolic parameters if they are also given growth hormone. Treatment with growth hormone may also help young adults to achieve higher peak bone mineral density. The principal side effect is sodium retention manifests as peripheral edema or carpal tunnel syndrome if given in excess. For this reason, growth hormone replacement should be started at a low dose with monitoring of the response by measurement of serum IgF. Regarding pituitary tumor, one of the presentations of pituitary diseases, pituitary adenoma are the commonest pituitary tumor in adults. Carcinoma is very rare and is most commonly ACTH or prolactin secreting tumors. Incidental pituitary lesions discovered on imaging, MRI or CT scan are called pituitary incidentalloma. Most pituitary incidentallomas are benign, non-functional pituitary adenoma. However, a small percentage may be Rathke-Clef cyst, benign embryological remnants, craniopharyngioma or meningioma. In patients with a history of malignancy, metastatic disease should be classification according to the size and according to the functional status of the adenoma. According to the size, microadenoma less than 10 millimeter, macroadenoma more than 10 millimeter, functional status, clinical or biochemical, prolactinoma 35 to 40%, non-functioning 30 to 35, growth hormone, secreting adenoma causing acromegaly 10 to 15%, HTH adenoma causing Cushing disease 5 to 10%, and TSH adenoma, which is rare, less than 5%. Clinical assessment of pituitary tumor. A common but non-specific presentation with headache, which may be the consequence of stretching of the diaphragmatically, mass effect only in macroadenoma, compression of the optic chiasma classically causes by temporal hemianopia. However, any type of visual field defect can result from supracellular extension of the tumor because it may compress the optic nerve, causing unilateral loss of acuity or scotoma, or the optic tract homonymous hemianopia, and also atrophy. Lateral extension of the cellular mass, as we mentioned in the anatomy, lateral extension will go to the cavernous sinus with subsequent compression of the third, fourth, and sixth cranial nerve, causing diplopia and strabismus. Another representation of pituitary tumors include hypopituitarism, clinical features of hormonal axis, if it is hormone secreting adenoma or tumors. Occasionally, pituitary tumors infarct or there is a bleeding into cystic lesion. This is termed pituitary apoplexy and may result in sudden expansion with local compression symptoms and acute onset hypopituitarism. This is discussed previously. Investigations, patients suspected of having pituitary tumor should undergo pituitary MRI or CT scan. All patients with paracellular space occupying lesion should have pituitary function assessment, assessing whether hormonal excess or deficiency according to the clinical features or according to the clinical suspicion. Consider visual field testing if it is large tumor or there is cellular extension with pressure on the optic chiasma or optic nerve. The definitive diagnosis is made on histology after management modalities of treatment. We have three modalities of treatment: surgery, radiotherapy, and medical therapy. Regarding surgery, most operations on the pituitary are performed using the transsphenoidal approach via the nostrils, while transfrontal surgery via craniotomy is reserved for supracellular tumor and is much less frequently needed. It is uncommon to be able to resect lateral expansion, lateral extension into the cavernous sinuses, although with modern endoscopic technique this is more. Urgent treatment is required if there is evidence of pressure on visual pathway. The chances of recovery of a visual field defect are proportional to the duration of symptoms, both for recovery unlikely if the defect has been present for longer than 4 months. In the presence of cellular mass lesion, it is crucial that serum prolactin is measured before emergency surgery is performed. If the prolactin is over 5,000 millinternational unit per liter or 236 nanogram per ml, then the lesion is likely to be macroprolactinoma and should be respond to dopamine agonist with shrinkage of the lesion, making surgery unnecessary. Pituitary function should be retested for a 6 weeks following surgery, primarily to detect the development of any new hormone deficits. Rarely, the surgical treatment of a cellular lesion can result in recovery of the hormone secretion that was deficient preoperatively. Following surgery, usually after 3 to 6 months, imaging should be repeated to assess for residual mass. Complication of surgery. All operations on the pituitary carry a risk of damaging normal endocrine function. This risk increases with the size of the lesion. Regarding radiotherapy, another modality of treatment, if post-surgical imaging show a significant residual mass and the histology confirm an anterior pituitary tumor extension, external radiotherapy may be given to reduce the risk of recurrence, but the risk-benefit ratio needs careful individualized discussion. Radiotherapy is not useful in patients requiring urgent therapy because it takes many months or years to be effective and there is risk of acute swelling of the mass. Stereotactic radiosurgery allows specific targeting of residual disease in a more focused fashion, which is called gamma knife surgery. Complication of radiotherapy, acute swelling of the mass, fractional radiotherapy carries lifelong risk of hypopituitarism, 50 to 70% in the first 10 years, and annual pituitary function tests are obligatory. There is also concern that radiotherapy might impair cognitive function, cause vascular changes, and even induce brain tumor. Medical therapy are a third modality of treatment options for pituitary tumor. First line treatment, dopamine agonists in cases of prolactinoma. Second line treatment in other hormonal axis adenoma, hormonal replacement in the presence of hypo. Non-functional non-functional tumors should be followed up by repeated imaging at intervals that depend on the size of the lesion and on whether or not radiotherapy has been administered. For smaller lesions that are not causing mass effect, therapeutic surgery may not be indicated and the lesion may simply be monitored by serial neuroimaging without a clear-cut diagnosis having published. This paragraph show therapeutic modalities for functioning and non-functioning hypothalamic and pituitary tumors. For non-functioning pituitary macroadenoma, the first line of treatment is surgery. Second line, radiotherapy. There is no medical therapy because they are non-functioning tumors. Prolactinoma, medical therapy considered the first line using dopamine agonist, which even in macroadenoma causes shrinkage of the microadenoma. Second line including surgery and radiotherapy. Acromegaly, surgery considered the first line, radiotherapy and medical therapy are the second lines of treatment. Medical therapy includes somatostatin analog, dopamine agonist, and growth hormone receptor antagonist. For Cushing disease, surgery first line, radiotherapy second line, medical therapy second line using steroidogenesis inhibitor and pasireotide. Craniopharyngioma, this is the first line of treatment, radiotherapy second line of treatment. Summary, investigations for pituitary disease including hormonal and biochemical lab analysis, radiological assessment, especially MRI of the pituitary gland, histology, and visual field assessment. Presenting problem in pituitary disease include either local pituitary tumor effect and the related clinical manifestations, hormonal excess and the related clinical manifestations, hormone deficiency and the related clinical manifestations. Hypopituitarism refer to either partial or complete deficiency of anterior and or posterior pituitary hormones. Pituitary adenoma are commonest pituitary tumors in adults. References the information taken from Davison Principles and the Practice of Medicine, 24th edition, 2022. This is the main reference. Another reference is Oxford Handbook of Endocrinology and Diabetes, 4th edition, published in 2022. Mixed up endocrinology and metabolism, the last edition. And thanks for all.